This is Jack. Jack has a bad pain in his abdomen, and it's getting worse. It gets so bad that Jack's wife phones the doctor. The doctor attends and thinks Jack has appendicitis. The doctor tries to phone the hospital to refer him for admission, but can't get through. He writes a referral letter and phones for an ambulance to take Jack to hospital. Jack arrives at the emergency department by ambulance. He's had some pain relief in the ambulance, but is still in some discomfort. He's worried about what is wrong with him. A nurse takes a handover from the ambulance crew and states that he's been seen by a GP at home. The nurse checks the list of expected patients, but cannot find Jack's name on the list for today. She tells Jack that he'll need to be seen by the emergency department doctors and then referred on if necessary. She apologises for the wait and explains that no cubicles are available at present. He's then sent to a cubicle to be seen, first by an ED nurse, then by a junior doctor. He's given pain relief. Investigations are requested and performed. A more senior doctor examines Jack again, who tells Jack that he thinks he has appendicitis. Jack is referred for admission under the care of the general surgical team. Unfortunately, the on-call surgical team are in the operating theatre, performing an emergency operation on another patient. The surgical registrar says that he'll come and see the patient in ED. So Jack has to wait until a member of the specialty team comes down to ED and agrees to admit him to the ward. All that's left to be done is for a bed manager to find a bed and a porter to take Jack to the ward, where 8 hours after he arrived at A&E, Jack is examined by a nurse, a junior doctor, a middle-ranking doctor and a consultant who discuss Jack's care plan. They decide that he needs a scan to rule out appendicitis, but the scan department is closed for the night. The scan is arranged for the following morning. He gets to theatre on the following day, but the delay means that the operation is more difficult. Jack has a gangrenous appendix and peritonitis, and develops a post-operative wound infection. His stay in hospital is prolonged, and he is discharged after 5 days. What could be more simple? Well, this could. When Jack arrives at the hospital, he's taken immediately to an assessment area and handed over to an advanced clinical practitioner and support worker. The ACP talks to Jack and prescribes a pain-killing injection. The support worker takes blood and orders the investigations. The ACP agrees with the GP that Jack has appendicitis. She knows that the hospital policy is that patients with suspected appendicitis have an ultrasound scan performed, so she requests this electronically. Jack feels reassured and more comfortable. He's moved to the multi-specialty emergency assessment unit. He is now under the care of the general surgical team. Following his operation, in which an inflamed appendix, with no spread of infection, is removed, Jack is transferred to the specialty ward, where he is welcomed by the ward nurse. On the following day, he's discharged home. Now, that is simple. Decisions are made more quickly, meaning there's less duplication, less confusion, more efficient use of resources, a better experience, and, most importantly, less chance of something going wrong. And, what matters most, it means Jack and patients like him get the care and treatment they need sooner rather than later. Our aspiration is to provide the very best quality of care for all our patients, irrespective of how, why, or where they present. Which is why the system needs to change.